Okay, so our next speaker is going to be Dr. Tamatha Urquart, and she's going to be speaking on best practices in allergy prevention and treatment. And Nestle Nutrition Institute Africa has facilitated her traveling around the country with us to all the in-person road shows. Now, in 2000, Dr. Urquart qualified as a pediatrician. In 2006, she completed a diploma in allergology and immunology, and she started a full-time private practice in 2006 and divides her time between the Pretoria Allergy Clinic, where she treats both children and adults, and practicing pediatrics at Kloof Hospital. And she's considered an expert in the field of allergies, and she's respected and honored both locally and internationally as an allergy specialist. Now, I'm going to be playing her recording and showing her slides. So if you just give me a sec, I will get it all going. Okay, I'm now going to hand over to Dr. Tamatha Urquart, and she is going to be talking about best practices in allergy prevention and treatment. And we thank the NNIA for bringing Dr. Urquart down to Cape Town for us. It really is an honor to have her. In 2000, she qualified as a pediatrician, and in 2006, she completed a diploma in allergology and immunology. And she started her full-time private practice in 2006 and divides her time between the Pretoria Allergy Clinic, where she treats both children and adults, and practicing pediatrics at Kloof Hospital. And she's considered an expert in the field of allergies. She's respected and honored both locally and internationally as an allergy specialist. So I'm going to hand over to the very esteemed. Thank you so much for coming to join us, and we really are looking forward to what you're going to say today. Thank you very much, Lynn, for that lovely introduction. And thank you for the opportunity and the privilege to be here today in your beautiful city on this beautiful day. And just to share some of my experiences and ideas on a subject I'm quite passionate about, and that is mainly on the prevention of allergies in children especially. So as we know, over the past 2 or 3 decades, allergies, the incidence of allergies have reached epidemic proportions. Initially, mainly in the developed world, but now also in the developing world. And between 10 and 30%, depending on where you are in the world, of the world population is affected by some or other allergy. Allergies normally start in childhood as a food allergy, which affects at least 6 to 8% of children. And commonly they present before the age of 6 months. It's very rare for a child to develop a food allergy after 12 months, but in medicine anything is possible. One of the most common allergies that we do see in children is house milk, mainly because that's the first allergen that they're really introduced to. And fortunately, in the case of food allergies, most have a very favorable prognosis, and most children will outgrow these food allergies, especially if handled correctly. So just before we start talking about how we can treat these children, prevent these children from even getting allergic, I thought I'll just go through a few important concepts in the allergy field and a few tidbits on immunology. So in order to become allergic to something, we obviously need to be exposed to it. And most people, after they are exposed to something, will become sensitized to it. So it means the body recognizes that this is a new protein, and there will be a bit of an immune response. In a genetically programmed person, this tends to move towards an allergic response. we're more interested in trying to make this baby or person tolerant and not allergic. And there are quite a few immune mechanisms that aid with the development of tolerance that we can use to our advantage. So if we look at allergies as a whole, this is very simplistic, but we get antibody-mediated allergies. Those are IgE-mediated, which is an immunoglobulin that we all produce to protect us against mainly parasites. For some unknown reason, some people are genetically programmed to make these IgE antibodies to form an allergy against a food or an environmental protein. Then we also get cell-mediated allergies, which can either be mediated by the B cells or the T cells. All of these are involved your humoral, which is your antibody immune system, and your cell immune system are all actually very integrated. So we do get a crossover between this, and sometimes we get in one patient a combination of antibody and cell-mediated allergies. It makes it quite complex. But just to get a bit of a concept, because fortunately the IgE-mediated antibodies are the most common, and they're the easier of the two to prevent and to treat. So if we look at your typical IgE-mediated allergies, they usually, in most patients, follow the allergic march. So the baby will begin early in the neonatal period, either with eczema or gastrointestinal disorders, or maybe both. These babies typically can present with severe colic or cramping, severe reflux, blood in the stools, even constipation, gassiness, fussiness. Eventually, this will then, as they get older, by about the age of 2 or 3, most of them will outgrow their food allergies, and then they start developing environmental allergies, which presents with hay fever or rhinitis, a runny or blocked nose, sneezing, postnasal drip, repeated respiratory tract infections. And then, if this is severe or it's not controlled well, they eventually will go on to asthma, and then usually adult asthma as well. So it's also important just to understand just a little bit about, I don't think anybody really understands the immune system or the immunology of pregnancy, but there are a few basic concepts that help us to understand how we can actually prevent these babies from becoming allergic. So the one thing is that in a pregnant mom, in the amniotic fluid, there are cytokines present, together with allergens that she's being exposed to. So whether foods that she's eating or animals that she's exposed to, and these are passed over to the baby. In an allergic mom, she has allergic cytokines. These are proteins that influence the immune system. And if her allergies are not well controlled, she has more of them. So there's more of a chance of this baby being sensitized. Whereas in a non-allergic mom or a mom who's being well controlled, she has more protective cytokines, which are then passed to the baby and help the baby tolerate. So it's important for the mom, especially if she's allergic, to be well controlled in pregnancy, so that her immune milieu is well controlled, that she's passing protective cytokines over to her baby. The other interesting thing is that moms that are exposed to allergens form IgGs, protective antibodies, immunoglobulin G. And these are also passed over to the baby, and they protect the baby against later exposure to these allergens. So this is important when we start talking about should moms be avoiding things in pregnancy. It actually seems like the more that they're exposed, the more antibodies they form, the better cytokines, unless of course they're allergic to it, and the more they protect their baby. And what actually happens in pregnancy is we all have a T helper 1 immune response and a T helper 2. Our T helper 1 is the one that protects us against viruses and bacteria. That's very important to be healthy and fight infections. Then our T helper 2 response is the one that causes allergy. That's the one that promotes IgE formation. And if that's in balance, then we're healthy, non-allergic individuals. The moment that becomes unbalanced and you get a T helper 2 predominance, then you start getting allergic. And often those patients will get more infections because their protective response is lowered. And there's a cell called a T regulatory cell, which produces our cytokines and our valuable cytokines that keeps that balance. In pregnancy, most women will just sway to a T helper 2 response, and that's because the baby is a foreign object. Half of that baby's genetic material comes from another foreign object, and the mom doesn't know it. So she could theoretically reject that baby. So So to prevent the mom rejecting the baby, her protective immune response dips a little bit and she gets a T helper 2 response. So theoretically, moms are in a bit of a state of allergy during pregnancy. And the balancing of this occurs in the 3rd trimester. So by that stage, the mom's immune system is used to this little foreign object and it starts balancing back to a normal response. And then after the baby's been delivered, the microbiome becomes the important part in balancing this immune response. So it's very important that the baby has a healthy gut microbiome, but also the skin and the respiratory microbiome is so important. And there's a lot of interest now in our microbiome, as I'm sure you're all aware. It's probably one of the most important factors in determining a healthy immune system. So, I'm just pressing all the wrong buttons here, sorry. The risk factors for allergy. Unfortunately, family history is the most important risk factor. Although you do get babies born with no family history of allergies that become allergic, that's where environment can play a big role, but your most important risk factor is your genetics. So if a dad's allergic, the baby has a 50% chance of being allergic. If a mom's allergic, 60%. If the mom's allergic and not well controlled, 70%. So it is a definite major risk factor. But then environmental factors play a big role. Babies that are born via cesarean section have a much higher chance of later developing allergies because they don't go through the vaginal canal and get colonized with the normal vaginal flora. They're born into a sterile environment and they get colonized by hospital bugs. If one's also too aseptic, the environment is aseptic, you're also going to get more, you won't be getting colonized with natural flora, but more hospital-acquired flora. The single children, because they're not exposed to as many, that's also debatable. There are good and bad bugs to be exposed to. Children that go to creche are being exposed to drug-resistant bacteria and all sorts of viruses that we've hardly even heard of before. But single children are not exposed to the common bacterial infections, so they tend to become a little bit more allergic. And then antibiotic use. Unfortunately, in South Africa, we have one of the highest rates of antibiotic use, and that sterilizes the gut and also affects gut health, along with PPIs and antacids, which our bacteria need. They all have a pH that they grow in, preferably at a slightly acidic pH. And by alkalinizing it, you also promote the growth of pathogenic bacteria. Then what protects against allergies are children that grow up in an environment with pets, especially if the pets were there before the child was there, if they're brought into that environment. And dogs seem to have a better protective effect than cats. Cats seem to sensitize and cause allergies more, but dogs, and 2 or more dogs is even better. So, yeah. If you play with children, you've got your animals, keep your animals. And then bigger families because of the exposure to more bacteria, and then rural environments as well, especially exposure to farm animals because they have in their feces lipopolysaccharides and endotoxins that seem to be promote a healthy microbiome in humans. Obviously, our diet will play a big role. If the baby's just fed processed and junk food, they're not going to have a healthy microbiome, and they're going to be deficient in a lot of nutrients. And we see that a lot these days. Babies born by cesarean section, the mom smokes, feeds them from about the age of 5-6 months. They're on bologna and 2-minute noodles and Oros, and they're at the nursery school, and then nobody can understand why this child's always sick. So all these modulate your gut microbiome, and it can even change your genetics slightly through epigenetic mechanisms. In some way, the immune system can actually, in a good or bad way, you can modify your genetic tendency to allergies. So if you're not that prone to allergies, but you have a terrible environment, you can manifest allergies. On the other hand, if it's a high-risk family, but you monitor the environment, you can actually lower that baby's risk for developing allergies. So that's what we would like to look at. So obviously, healthy foods, breast milk, and the use of probiotics will encourage a healthy gut microbiome and a healthier child. So now we get to the crux of the talk, which is actually how can we prevent allergies, especially in these high-risk babies. So as I said, family history is your most important risk factor in allergies. So those are the babies that we're going to be concentrating on. There's three strategies you can apply. There's primary prevention, secondary, and tertiary. I'll just be looking at primary prevention mainly today. So this is in your high-risk patients that you suspect are going to have a high risk of developing allergies. How can we prevent them from becoming allergic? Once the allergy is already developed, there are some secondary strategies that we can implement to stop the baby from progressing further. And then our tertiary ones would be in the older patients, things like immunotherapy, where you give them what they're allergic to in a controlled manner and try and develop a resistance. So, for example, if you're grass allergic, you can get sublingual or subcutaneous immunotherapy with grass pollen, and that actually stimulates the immune system to form IgG, almost like a pregnancy, to protect the baby. But I won't be going into that today too much. What I want to concentrate on 8 primary prevention methods or factors that we can look at. So one of the most important is the maternal diet during both pregnancy and lactation, breastfeeding. For babies that can't be breastfed or non-exclusively breastfed for whatever reason, I'll look at the use of partially hydrolyzed formula. When should we wean these babies and introduce weaning foods? How can we manipulate the environment? The use of emollients, because there's this dual allergy hypothesis theory that we're not only being sensitized through our guts, but actually through our skin as well. Then how can we use prebiotics and probiotics to modulate our gut microbiome? And then just looking a little bit at the, that is actually fits in with breastfeeding, the human milk oligosaccharides. So one of the big ways that we can help to prevent allergies in the neonates is to look at the mom's diet. And there have been hundreds and thousands of studies done on this, trying to see if giving extra vitamin C or D or omegas, vitamin E, what supplements will protect the baby. And there have been many studies for and against all of these factors, but not many conclusive ones. The only one that seems to really make a bit of a difference is vitamin D. So at this stage, there's little data to support trying to manipulate a mother's diet with these supplements and nutrients. And then if we look at maybe trying to avoid the allergens, the 6 major allergens like cow's milk, egg, peanuts, wheat, fish, seafood, and now sesame is also becoming quite an important allergen. There have been lots of studies thinking if the mom avoids all these in pregnancy, would that make a difference? And actually, there have been several reviews done on these, looking at different trials, and it actually, none of them have actually shown a decrease in allergies in its children. About 20 to 30 years ago, there was a big movement, especially in the UK, but also in the United States and Australia, where they were recommending that mothers avoid most of the allergenic foods during pregnancy, especially high-risk babies. And actually, the incidence of allergies increased in that time, in the last 20 to 30 years that this has been done. And it's probably because these babies weren't being exposed, so they weren't being sensitized and they weren't becoming tolerant. And the first exposure that they got was after birth, and the body saw this as a foreign protein and immediately had an immune response to it. So there have been several studies, but no decisive conclusion can be made that cow's milk or egg allergy is decreased in these children. There are 1 or 2 that have shown it, but there are so many other confounding factors. So at this stage, there's no recommendation to add to the mother's diet with supplements or nutrients, or actually to avoid any foods, unless of course the mother's allergic to them. And the problem is that our nutrients and foods are not normally eaten in isolation. So if you increase your intake of one, you might actually be decreasing your intake of another, which could be affecting the outcome of the studies. It's a very challenging area of research. Anything to do with pregnant women or babies is challenging because it's very difficult to randomize them into 2 groups and to tell the one group to have lots of vitamin D and the other one to have little or no vitamin D. It's a bit unethical. So it is a challenging area. And because our immune system is so incredibly complex and our environments are complex and there's so many confounding factors, it's difficult to actually make recommendations in these regards. But all that has really come out of these studies is that all these interventions don't seem to be actually helping. And what has come out of these studies is that a diverse diet seems to be more protective. So if a mom's eating healthily and getting her omegas and all her vitamins in via natural foods and not supplements, she's going to have a healthy microbiome, which is going to lead to a more diverse and healthier microbiome in the infant. And if she's eating a healthy diet, she's going to have her omega-3s. The non-digestible fibers are very important as prebiotics for the microbiome. And all of these will be exposing the baby as well to diverse sets of allergens. And so this baby is going to be exposed and sensitized. And through other forms of manipulation, you can actually try and make that baby develop oral tolerance and become tolerant to all these foods. And then this can carry on into, after pregnancy, into breastfeeding. As we know, I mean, I don't have to tell you all the hundreds and hundreds of benefits of breastfeeding, but I'm just going to mention a few things that will help prevent allergies in the breast milk. So a very important cytokine. A cytokine is a protein that affects your immune system, that plays a role in modulating your immune system. So one of the most important ones in promoting a healthy Th1 response and a balanced immune system is tumor growth. Is tumor growth factor beta. I think that suddenly I've gone blank. It's not tumor growth factor. Anyway, TGF beta. And my word bank is finished today, sorry, but I'll think of the word just now. But anyway, this cytokine influences the development and maturation of the baby's mucosal immune system, and is very important. It's one of the most important cytokines in a healthy Th1, Th2 response that will promote oral tolerance. Oral tolerance is basically making the baby tolerant to the intake of oral antigens. Another very important protein that we get in breast milk, and that is now actually being, a lot of infant formulas are being supplemented with it, and even in some parts in Europe you can buy it for adults as well. These are complex oligosaccharides that actually act as a prebiotic. So our healthy, or our gut flora uses these, especially the bifidobacter, and they take the HMOs and they break them down into small chain fatty acids. And this is the main metabolite of our gut flora, and they are also very important for to enhance our oral tolerance. And they may actually be one of the most important molecules or proteins in the prevention of allergy. So just summarizing what happens during breastfeeding, a mom sometimes inhales, she can swallow pollen in the air. And then this is digested by her digestive system. The proteins are then excreted in her breast milk, along with all those immunogenic factors that I was talking about, the healthy immunoglobulins, all the cytokines get excreted into the breast milk. The baby ingests them, and these then they transfer to the baby's gut and stimulate a healthy microbiome, healthy enterocytes, and the lymph nodes we've got a lot of lymph nodes in our gut, are then stimulated into a healthy, the regulatory cells are stimulated, and this baby then develops a healthy immune response.
TGF is transforming growth factor.
Where I got tumor from? Tumors on the brain, transforming growth factor, sorry. As I said, it sounds really wrong, but I couldn't think what the right word was. The latest recommendations now from the World Health Organization and the pediatric European can you hear me? I'll carry on without it. So the European Society of Pediatric Gastroenterology, their latest guidelines are that breast milk is one of the most important breastfeeding mechanisms to prevent allergies in high-risk babies, and especially the food allergens containing peanuts, the overalbumin in egg, wheat, and then your beta-lactoglobin is the main milk protein that's excreted from cow's milk into the mother's breast milk and taken in pregnancy that stimulate oral tolerance in the baby, and it's even been shown that it could be protective against autoimmune diseases later in life, because an unhealthy immune system, if it's dysregulated, is going to make you more prone to allergies, to immune conditions, and to autoimmune conditions. So, early intake of these allergens has been shown to be protective against infections. It obviously induces tolerance to that specific antigen and also improves our microbiome. So what we can say now, after the last 2 or 3 decades of studies, is that antigen avoidance in pregnancy and breastfeeding does not decrease your possibility of allergies. In fact, it could have the opposite. So no guidelines now recommend any elimination diets in pregnant women for allergy prevention. Obviously, it would be different in cases where the mom's allergic to the food. We wouldn't want her to be ingesting it then. And so moms with a definite diagnosed allergy, only those should be eliminating the offending foods. And then it seems to be that, continuing breast milk while you're introducing solids also has an extremely beneficial effect on the baby, because all those immunotolerogenic cytokines are being expressed in the breast milk, presenting them to the baby, and that foreign protein that the baby's being exposed to isn't so foreign anymore. So weaning around about the age of 17 to 26 weeks is a good idea to start introducing the solid foods, but if the mom can carry on breastfeeding in that stage, even better. The baby's ability to develop tolerance will be even more effective. So then my third thing I wanted to speak about was partially hydrolyzed formulas. As much as we love all mothers to breastfeed, there are cases where they don't have enough milk initially, or the mom's sick or something happens, or the mom's not around, we might need to supplement these babies with formula. So as a normal cow's milk protein formula will have big cow's milk proteins. What you can do is by enzymes hydrolyze these proteins. So that means break them down into smaller molecules. So if it's partially hydrolyzed, it means about 70% of the proteins are broken down and into sort of bigger peptides and polypeptides that can be more extensively hydrolyzed into smaller peptides. And then if in the case of a really severely allergic baby, we can break it down into small amino acids, and those are your amino acid bases. Thank you. Formulas. So as you hydrolyze the protein more, the allergic reaction becomes lower and lower and lower. The only problem is the more you hydrolyze it, the less protein or antigen there is. So you're reducing the chance of oral tolerance in this baby, because there's no protein for it to become tolerant to. So that is a little bit of a problem there with amino-based formulas. So what happens when you partially hydrolyze the milk, you remove the sensitizing epitopes. The epitopes are like antigens or proteins, and those are the ones that make the baby allergic. So the allergenic potential of this milk is reduced, but there's enough protein and they're big enough that you can still get oral tolerance in this baby. So that's ideal. It's less allergenic, but you're still giving tolerance to the baby. There's been a lot of debate about, can we prevent cow's milk or allergies in totality by giving these babies partially hydrolyzed formulas. There was one very promising study, which was the Genie study, which was started in 2000, and they followed thousands of babies up over 20 years. And they found that giving them a partially hydrolyzed formula significantly decreased eczema or atopic dermatitis in these babies for up to 15 years after birth. And they also had a decreased risk for asthma. Unfortunately, there have been subsequent studies that haven't been able to reproduce this, but they were smaller studies. But it does look promising. Then the next thing I want to just touch on in avoiding allergies is, when should we, I did allude to this now, when should we start weaning these babies onto solids? And research once again has shown that actually earlier ingestion of antigens is more beneficial in promoting oral tolerance, because the baby's immune system is still developing. The later you wait, and once the immune system, by 6 months, the baby's immune system is functioning well, and then they might develop a stronger immune response, an allergic response against something that they've never been exposed to. So there's been a big shift away from later introduction of foods into earlier introduction of foods. And the LEAP study, which I'll talk about just now, they looked at, in the UK, the recommendation was that peanuts, because they've got the highest incidence of peanut allergy in the world, and their recommendation was to only introduce peanuts up to 60 months or 5 years. But their incidence of peanut allergy was just rising. And then Gideon Lack, along with the South African George Detroit, decided to study this because in Israel, the babies are introduced to, I think it's called tahini, I must just check what it's called, but it's sweet. Is it tahini? Oh, tahini sesame. There's something, they make a paste. Maybe the tahini's got peanut in as well. They give the babies a peanut paste from 4 months. And Israel's actually got one of the lowest incidences of peanut allergy in the world. So they did a study in high-risk infants between the two countries, and they started even in high-risk babies with other allergies, early introduction of peanuts. And they actually found that not before 4 months, but the earlier, as close as possible to 4 months that you introduce peanuts, the lower the incidence of peanut allergy. And this was also seen in another study that they did just after that, which was the EAT study. That study, they looked at 6 proteins, the 6 major proteins. They found this to be very true for egg and peanuts, but milk, there was a slight lowering in milk allergy in these children, but not as dramatic as in egg and peanuts. So there might be other factors involved with cow's milk. So after this, these studies were published. The American Academy of Pediatrics recommended that we introduce peanut between 4 and 12 months, earlier rather than later, especially in countries with a high prevalence. And then egg should be introduced, and it should be introduced initially well cooked, because the more you cook it, the less allergenic it is, between 6 and 8 months. And then just after that, Urquart actually said we could start a bit earlier, between 4 and 6 months, and try and get well-cooked egg at least twice a week, because we want to maintain that tolerance. There's absolutely no evidence for delaying, unless, of course, there are neurological problems in the child and they can't eat, but there's no other reason to delay introduction after 6 months. And also, we shouldn't be introducing before 4 months, mainly because of the risk of aspiration and choking. The baby's not neurologically developed yet, and the gut enzymes also. So that's got not much to do with allergies, but more with maturation. So it seems like between the ages of 17 and 26 weeks is the best time to start introducing solids in babies. So if we're trying to get tolerance, the 3 most important factors are try and breastfeed the baby, introduce as many food antigens during pregnancy and breastfeeding, and then promote a healthy gut flora in the baby, obviously through human milk and antigens, but also through the environment. And that's why we're shifting back to try and encouraging moms to deliver normally. And then the 5th factor I want to look at is environment. There are a lot of environmental factors that have been studied. As I've said, one of the highest risk factors to develop allergies if a baby has been given antibiotics, especially in the first year of life, because that disrupts the gut flora. We can try and give them probiotics along with the antibiotics, but the problem is each of us are genetically programmed to have our own microbiome, and at this stage we don't know what should our dominant gut flora be, what's the ideal mixture for us. It seems like everybody has their own little recipe. That will probably come now with the studies in genetics, and they're busy studying everyone's genes, and we'll actually be able to get a little printout of what our healthy gut microbiome should look like and what we should be supplementing with. But at this stage, we're still just guessing. So, so obviously, by wiping out the baby's microbiome, we are going to affect their immune system. Then pollution and exposure to cigarette smoke also plays a big role in increasing the incidence of allergies in children, and it seems like it's actually also through microbial dysbiosis in the gut that the gut flora get affected by it. Living on farms and forests, that's part of the hygiene hypothesis. The more natural antigens that a child's being exposed to, and bacteria, but healthy bacteria, not hospital like Clostridiums and superbugs, those aren't going to be any good for the immune system, but lipopolysaccharides and exotoxins from animals also stimulates the immune system and balances the T1 and T2 response. A lot of other studies have also been done on, like on the dogs. A child born into a house where there's 2 or more dogs seems to be more protective against allergies in one brought into a house where there's no animals. Cats seem to make them more allergic. House dust mites. There seems to be too much exposure will make the child allergic, and too little exposure will not give them protection. So you sort of need the balance in the middle. So the house should be clean, but not too clean. And then this is the dual allergen hypothesis, and there's been quite a bit of interest in children with eczema. What was first, the chicken or the egg? Did they have this, or get born with the eczema and they started absorbing allergens through their skin because their skin barrier function was disrupted? Or did they become allergic and then develop eczema? But it seems like a lot of children are actually being sensitized through their skin. So we must be very careful what we're putting on the skin of children. At some stage, they were adding peanut oil to mulligans, and the incidence of peanut allergy rose tremendously. So if a child is exposed to its initial allergen through the skin, it seems to stimulate a Th2 response, and that's the one we don't want. Whereas if they're given it orally, it goes to their mesenteric nodes, those are the ones around the gut, and stimulates more the Th1 and the T regulatory cells. So that's where the interest came in, maybe putting topical emollients on these babies early and protecting their skin against exposure, especially high-risk babies, because any compromised skin is going to be a risk factor for the microbiome being dysregulated and antigens being absorbed. And there are a few studies that have shown that good skincare, not putting anything on the baby that is a fragrance or an additive or a preservative in, but just as natural as possible, something like Epimax or E45 or Eucerin, may decrease allergens and desensitization. And some studies have shown that it can actually prevent eczema. It's also still a little bit wishy-washy at this stage, but it won't harm the baby, so it's worth a try. Then we've spoken a lot about the gut microbiome. So we get prebiotics, which are things like fiber that feed the bacteria in our gut so that we have a healthy gut flora, and we can actually give patients these microbes in the form of a probiotic. And then what happens is, if you've got healthy bacteria, they're going to produce these short-chain fatty acids, which we can also give the baby. We can give a lot of formulas, and foods are being supplemented with postbiotics as well. And does this help at all? So a few studies have shown, even a Cochrane study, that it might have a potential benefit if you supplement the baby with the prebiotic, especially if they're getting antibiotics, in preventing eczema. But there's no conclusive evidence and insufficient data at this stage for us to propagate this widely. But I think it might be also because we're still not sure which probiotic for which baby, but I think that's still coming. So as in the English language and in medicine, there's always an exception to the rule. So some of the exceptions are, what would you do in a family where either the parent or a sibling, especially a sibling, has got a severe peanut allergy? It would be quite dangerous, first of all, to the sibling to be giving, normally one would recommend that household be totally peanut-free, because some children are so allergic that even inhaling it or touching somebody who's touched it would give them an anaphylaxis. So it's very difficult for their siblings, and I get asked that quite a bit, what we do, because we want this second one to be tolerant. But the problem is all the siblings, all the younger siblings, or any sibling of a peanut allergic child, have got a 7 times higher risk of developing a peanut allergy. So in that case, I recommend to the parents that they rather bring the sibling in without the allergic one, and that we test the child first, and if they appear not to be allergic, that this child then be given peanuts out of the home, so at a granny's house or somebody else's house. But obviously they won't be able to eat that at home and be kept away from the older sibling. Then the other group of children is those with moderate to severe eczema or atopic dermatitis. These children have got a much higher risk of being allergic, especially to the major food allergens. So if a child has got very severe atopic dermatitis, it might be a good idea just to have them tested before you start with the solids. And if there is a risk of allergies, to have those foods introduced even in the doctor's office. Sometimes I just say to the parents, go and sit at the coffee shop near your local casualties and introduce the food there. And if there's a reaction close by, to any medical help if you need it. Or in the afternoons, we have picnics at our offices, and the parents who want to introduce food will have all the eggs on one day, and they just come while I'm working. I don't charge them for it. They sit there and introduce the food just so that they are close by. I'm close by if there's a reaction. But I mean, that is very difficult, especially in areas where there isn't that type of medical care. So these are a bit of a difficult group. And the latest recommendations from the American Academy of Allergy and Immunology are now that we should be introducing in these high-risk babies one food every third to fifth day in an age-appropriate manner. So you obviously would start with raw carrots in the babies. According to the neurological development, but they recommend starting with grains. I like to start with the yellow and orange vegetables like butternuts, pears, sweet potatoes, and then you go into your greener vegetables, and then the grains. Start with rice, cereal, and then maize, and build up to wheat. And as soon as the baby's tolerating these foods, then you must start with your allergenic foods, your eggs and your peanuts and fish, and try and get as many as you can in before 6 months. And these foods, I think this is actually common sense. You shouldn't be letting the creche give a baby its first introduction to a food, because you can obviously react with your first ingestion. It's not like the blue thing where it gets worse. Well, probably would get worse with every injection, but the baby can actually react to its very first exposure. So if there's no reaction on the first day, always do it in the morning and then just gradually increase it over 3 to 5 days. And then it's also important that the baby must regularly ingest that food. So once it's tolerating something and you introduce new food, then you can start making mixtures of your vegetables. So that at least twice a week the baby is being exposed to each different allergen, because they can actually lose tolerance if they're not exposed regularly to it. But the frequency is not really known, but probably about once or twice a week would be a good idea. And then I just want to touch on, I think I'm going a bit over my time, but maybe on the secondary prevention. So this is a baby now that's already allergic, and you want to prevent these allergies from worsening. So in those cases, we've got the 3 hydrolyzed formulas that I spoke about, and we can once again modulate the gut with pre and probiotics. So the extensively hydrolyzed formulas are normally your first line in a child with cow's milk allergy, unless they're anaphylactically or severely allergic. You start with an extensively hydrolyzed formula, which are the ones that are mainly peptides and smaller peptides. Then, in the case where a child has anaphylaxis, or if they've got severe eosinophilic esophagitis or colitis, when they start passing blood in the stools, we would first, just to get that gut healthy again and get rid of the inflammation, start with an amino acid formula. The problem with these is that they're very costly, and a lot of parents can't afford them. So if the extensively hydrolyzed formula has not been effective, or the child has anaphylaxis, or if they've got multiple food intolerances, one would give them an amino-based formula just until that gut is healthy, the symptoms have disappeared, and then go on to extensively hydrolyzed. Because the problem with an amino acid-based formula is there's not enough allergen in there to promote oral tolerance. So if you keep a baby on an amino acid-based formula for a whole year, they are going to get no tolerance to cow's milk and probably then start reacting as soon as you introduce smaller amounts. So try and get them off the amino acid-based formula as quickly as possible, so that we can get oral tolerance. There's also been recent studies showing that if we put symbiotics, pre and probiotics and postbiotics in there, that can also promote immune tolerance. So that was just what I wanted to also say on the other slide, is that even in the secondary prevention of allergies, pre and probiotics, there are studies that have shown them to be effective. Oh.
I'll put it's the load shedding. So
it'll kick in now. Oh, okay. So, that was, what am I doing now? I'm going to sit it down. And I think that was more or less everything I wanted to say. And then there was just a bit of a summary of what we've just spoken about now. So basically, exclusive breastfeeding for the first 4 to 6 months are the most important factors in avoiding allergies. Exclusive breastfeeding in the first 4 to 6 months of life. There's no evidence that changing the mom's diet and supplementing with all sorts of supplements makes a huge difference. Let her eat a healthy, diverse diet. Introduce the allergenic foods as quickly as possible between 4 and 6 months. and once you've introduced them, carry on introducing them or keeping them in the baby start to maintain oral tolerance. Yeah, so that was what I wanted to say today, and it was a bit of a mouthful. I hope you're all awake, and if anybody has any questions, you're welcome to ask them now.
Thank you for the wonderful information. I just have one question. You suggest that we start what other foods instead of grains. Is there any rationale for that?
It's actually more a personal preference because I know that a lot of the guidelines suggest the grains, but I just find the more tolerable to the babies, especially because they can have a wheat allergy. So I just like to get them used to the texture of the foods and then start with the allergenic foods. Yeah, because if you do start with a grain, then it's better to start with a hypoallergenic, like a rice with no added dairy. So it's more also for the neurological, get the baby eating before you start introducing all the, so get used to the texture of the swallowing before you start introducing the allergenic foods. But, if you started with a grain, that wouldn't be wrong.
Now, I just wanted to ask you, for the microbiome, we like the babies on the mother's chest breastfeeding, but in most hospitals they take them away, weigh them, do the measurements, do the alcohol rating, and so they're stopping that anyway.
Yeah, I think a few minutes away from the mom's side, that the kangaroo care, obviously the baby's inhaling, our skin has also got a wonderful microbiome, so that skin contact is also very important, and also not bathing the baby maybe for the first 24 hours. But yeah, a few minutes being weighed and measured isn't the end of the world, but as long as the mom's maintaining that skin contact for the rest of the time, where possible. I mean, obviously there are cases where the baby has to go to ICU and you can't do that, but where possible, I would recommend that.
So, prebiotic and probiotic, we usually recommend probiotic when we prescribe antibiotics. When would we recommend prebiotic and for how long?
So your prebiotics, mainly the best prebiotic is to eat a good diet with fiber and things like that. So put the baby on as long as the baby's eating healthily, yogurt is a very good pre and probiotic. But always give a probiotic with it as well, just err on the side of caution now. But as long as if they're eating a healthy diet, we've got prebiotics in fruits and vegetables and in our grains with the fiber. Yeah, so I wouldn't say a prebiotic with your antibiotic, definitely a probiotic as well. Studied the most is Rutary, Lactobacillus ruteri. So that's got the most scientific evidence behind it. That's the one I use, but it probably isn't the ideal one for everybody. We don't really know what our I tend to use Rutary in most patients because that's the one that's been. But I mean, you're right. It might work for most patients, but not for everybody. So it also depends on your genetic constitution, and unfortunately, we still don't know that, but hopefully one day soon we will.
I'm just curious, I have a baby, and he's very prone to his, like, tested him with nut allergy. So the mom has had him on HI formula, and it's 12 months now. How regularly should I actually recommend to start weaning? When would you say, if they are using a hydrolyzed formula, how regularly should they try and switch over or see if the baby can maintain?
Karina Fenton, she's a South African dermatologist, and the NHS started you get a 12-step and a 6-step. But I would say the 12-step milk ladder, and then basically you start off this recipe that they are actually more UK-based foods that they're using, but there's a recipe attached to it. And you start off with a biscuit that's just about got no milk in, and then give a baby a quarter and then a half and then a full biscuit over a week. If a baby tolerates that, then you go on to the next step, which is a biscuit with a little bit more milk protein. Then you go into a muffin, and they gradually increase that over, and every week you go up with a step on that ladder, and eventually you're on lasagnas and what else do they put these? Pizzas and chocolates and yogurts, and so it's a good idea after a year you can do that to the baby, and then just see if the baby starts reacting at a step. Go back a step and do that for about 4 weeks, and then try again, because we want to. That baby's probably going to outgrow his milk allergy, or nuts and peanuts are a different story. But if it is a milk allergy, and it's not a proven milk allergy in that child, but it does seem, if your gut's inflamed because of another allergy. For some other reason, a lot of babies can't tolerate cow's milk protein. So it might be more a gut issue than an allergy issue. But then just slowly over those 12 weeks, every week you go up a step until you get the baby onto cow's milk. But if you get stuck on a step and the baby's not ready, but he has tolerated the steps before, just go back, wait 4 weeks, and then start again. But we want to try and introduce it as soon as we can.
One last question. Okay. Oh my goodness. Okay, you'll make 2 questions. Just want to know, I've got a grandson. He's now nearly 6. He did have a little bit of allergies on eczema and so on, but all of a sudden he just flares up. He's from head to toe, rough skin, even on his little winky. He just has eczema. Is like the walking eczema. They took him off bread. They now this week started taking him off milk. What else? And he's on Ritalin now. He's on immunities. What do you?
Eczema is very multifactorial because eczema, but there are a lot of non-allergic contributors. So some children are just very sensitive to heat or dry air or to chlorine in the pool or to sunscreen. So it could be something that you're putting on it. It could be that he's developed an environmental allergy. House dust mite is a common cause of eczema flares. But I think in that case it's better, instead of trying to figure it out yourself, to do a skin prick test. I believe in a skin prick test, like especially in an eczema child, take him to an allergist and get a skin prick test. But it might be a house dust mite or something like that. Yeah. And his mattress, how old is his mattress? Yeah, there might be house dust mite in his pillow, his mattress, or his teddy bears in his room. The coastal towns, the Cape and Natal have a higher incidence of house dust mite up in the Highveld. So it could be a house, it could be a grass pollen, an animal dander in there. Yeah, it doesn't matter how clean you are, there could be house dust mites in the area.
Okay, one last question. Yeah, I was just wondering, with COVID, have you noticed an increase in allergies in little ones during that time period because of the antiseptic?
Yeah, I think it's the antiseptic and a lot of more eczema because our microbiome has been annihilated. A lot more eczema, but also just the immune dysregulation of COVID. Moms that got COVID when they were pregnant, those babies are immune dysregulated, and allergies are an immune dysregulation. So a lot more autoimmune diseases, babies' immune systems have been affected, and I'm seeing an absolute surge in allergies and immune problems. Yeah.
Good people, hopefully you enjoyed that session on allergies. It's always good to hear what they're finding out and what the recommendation is. So we say thank you to the NNIA for bringing us Dr. Urquart to speak on best practices in allergy prevention and treatment.